So you are listening to me, okay?
Yes, sir.
Okay, good. I think this is a very important topic that you must all be quite aware of, and you must what you call the master in this topic is abdominal wall hernia, because this is a topic that every medical doctor should understand very, very well. Okay, that's why it's very important, and it is said to be a bread and butter of not only surgeons, everybody. And to understand hernias, you have to understand it's basically the anatomical defect causing the disease. Okay, that's why you must understand the basic anatomy of abdominal wall to understand this abdominal wall hernia. So I'll be taking in two classes. One, today I'll just talk to you about the basic principle of hernia, and before that I'll talk to you about something about the anatomical muscular anatomy of abdominal wall, and what are the causes of this hernia, and there are different type of hernias. Then on Thursday, I'll be talking to you in a specific hernia as such. So if you see, the basic principle of hernia is almost same. So there are some few differences depending on the site of the hernia. That's very important. Okay, that's why it's very important. So I'll be taking very basic class today. You know better, and just recapitulating you about this thing. Okay. If you see the landmark of abdominal wall, uh, the Giffey-sternal point, that is the lowest point of Giffey-sternum, and you can see there are muscles, the lineal alba vertically coming from Giffey-sternum to symphysis pubis. In between there is umbilicus, and if you go to laterally, you see the costal margins. Okay, these are the costal margins coming like this, okay, and they are all abdominal muscles. And the most is the electress anterior spine, is right in front. The electress is the posterior highest point of electress, and this is what you see is inguinal canal just parallel to the inguinal ligament coming from the anterior spine to pubic tubercle, and this is and all the muscle markings. These are all these transverse intersections of the rectus muscle. There are 2 or 3. You see, so that makes this muscle packs. That's known as muscle packs. This is what anteriorly you can see the abdomen as such. Okay. So if you open the abdomen and take out all the skin and peritoneum, what you see is this is your chest case. Okay, this chest case. So if you see the abdomen divided in 3 parts of abdominal cavity. One is intrathoracic, one is in the pelvis. Okay, in the pelvis also there is abdomen which is covered all around by bone. This bones anteriorly and sacrum posteriorly, and again this is iliac bones. They cover posterior lateral part of this, but this anterior part is open. So this is known as the one covered by the pubic bone is true pelvic abdomen, or the one is open anteriorly. That's another false, not true pelvic abdomen, and in between this two abdominal cavity. No any bone.
Excuse me, sir.
So
Hello. Excuse me, sir.
yes, sir. Yes.
Sir, हजुरको voice अलि unclear आइरहेछ.
Unclear आइरहेछ. Okay.
बल्ल clear भयो.
Clear भयो?
अहिले भयो.
Okay, thanks. So thoracic abdomen, pelvic abdomen, that's true and false pelvic abdomen, and abdomen proper. That's how they are divided. What you call diaphragm to diaphragm, thoracic diaphragm to pelvic diaphragm. That's true abdominal cavity as such. Okay. Now you see, if you see the muscles covering the abdominal wall, If you see the lateral serratus anterior most laterally, then you can see transverse abdomen, then anterior anterior, this is external aponeurosis, oblique aponeurosis, then transversus abdominis, then internal oblique. This is most superficial layer is external oblique, then internal oblique, then transversus abdominis. There are three layers you can see. Okay. Then below that you have got fascia transversalis, and more anteriorly these are all laterally. Okay. These are all laterally. Once they come medially, they form a tendon. You see in the external oblique, you can see the tendons in the internal oblique, the tendons in the transversal abdomen. So, and they join together, and more medially, there is one muscle known as rectus abdominis. Okay? And these are the transections, tendinous insertions of the rectus muscle, so that it becomes so strong. If you don't have any tendinous insertion, it will have a very flabby sort of muscles. Because of this fibrous tissue crossing the transverse fascia, rectus abdominis, you will see they are quite strong muscle. So these are the packs. You can see when somebody has a good body figures, they have a packs. Okay, like that. And laterally, they are sorry. Laterally, they are all what you call. You have got this tendinous muscles, tendinous muscle of the external, internal, and fascia transversely. So this is what the anterior abdomen look like. So when you just open the abdomen, first you will inside the skin, then will come to the tissue, then you will come with the fascia, what you have seen, above the umbilical and below the umbilicus. Uh, there are camphor and scarpa, there are deep fascias. Then there's anterior seat and posterior seat, then external oblique muscle, internal oblique and transversal muscles, then periperitoneal fat and parietal peritoneum. I'll show in this picture. You see, if you see this picture, this is the skin, soft tissue. This is the seat. Okay, in between there are deep fascia, it's scapha and camphor, and this is anterior seat, this is rectus muscle, and this is posterior seat. Then you have got periperitoneal fat, and you have the parietal peritoneum. So these are the layers of abdomen wall. If you see how they arise, the external oblique aponeurosis, the external oblique muscles, they throw one sheath, the sheath of the external oblique aponeurosis. So they go and oblique, when they have the sheath, they split in two. One go anteriorly, one go posteriorly, and they join anteriorly with the sheath of the external oblique. The one below one, the internal oblique, the posterior one, it joins the fascia of the transverse muscle like this. So they join seat, posterior seat in between this muscle, and they join the other side of this fascia or anterior seat or posterior seat, and they press it together and form the lineal. So this area is known as lineal. And you can see the preperitoneal fat layer and parietal peritoneum. So this is a typical anatomy up to the level of halfway between the umbilicus and the symphysis pubis. Halfway between, you will see this type of all that anatomical picture. But once you go below the halfway from umbilicus to symphysis pubis, what do you see? If you just minutely see all the layers, all the seats, muscle seat that is coming from external, internal, or transverse, they go, they go they go anterior to the rectus seat. There is no posterior rectus seat now. You see, there is no posterior rectus seat like here, like above the line. So you can say this is the line. So this is the line. That is not an arcuate line. So above the arcuate line, you will have a typical picture of what you call the abdominal wall. All the seats, they go anterior to the rectus seat. So there is devoid of posterior rectus sheath below the arcuate line. So this is known as semilunaris. Arc is semilunaris, also they are known as semilunaris. So when you open abdomen, above the arcuate line, you have to open all these layers. But below the arcuate line, you don't have any what you call directly. Once you remove the mobilize the rectus sheath, you will directly go to the periperitoneal fat and peritoneum. That's the difference of abdominal wall anteriorly. Okay, this you have to remember. This diagram, if you keep it in your mind, you just remember exactly. You don't have to describe. You will understand how does the abdomen and anterior-abdominal wall musculature is formed. And there are a lot of vessels and a lot of lymphatics. And if you see the umbilicus is the point, above the umbilicus and below the umbilicus, all the drains above the umbilicus is the axillary vein or axillary artery or axillary lymphatics, and below the umbilicus they all drain into the inguinal uh, arteries or inguinal vessels, inguinal lymphatics. So this is watershed area. Above that umbilicus, they all drain to the superiorly, and below the umbilicus they all drain inferiorly. Okay, that's the vasculature. I'm not going to talk all detail about these vessels. So these are the things. The most important vessel that you might come across is inferior epigastric artery below, and axillary artery or internal thoracic vein or axillary artery above. There are two very important vessels you must keep in mind when you open the abdominal wall. Now, if you see internally and you go posteriorly, we're talking all about this anterior abdominal wall. So the posterior is a completely different story again. Okay. Once you open the skin and soft tissue, you will have a very wide thoracolumbar fascia. They run anterior to posterior. And you can see the muscles which are very much important and covering the posterior abdomen is latissimus dorsi and serratus anterior posterior, quadratus lumborum, psoas major and minor. So these are the 5 muscles. They are very much cover the posterior abdominal wall. Okay, so and the posterior abdominal wall, you will see a lot of important and big vessels, IVC and aorta, and the branches and tributaries, and the lymphatics also. They all have the drainage system in the abdomen, and then they go to thoracic vessels in the thoracic cavity. So this is a picture you can just remember and keep a picture in your mind, and you will be able to understand this thing. But if you see again, this picture is very important. So if you see posteriorly, you can see the skin and the soft tissue, and you can see the laterally, dorsi, and there are all the 3 muscles: external, internal, and transverse muscle anterior abdominal wall. They come out from this sheath. You see, this is sheath formed by the muscle erectus spinae and quadratus lumborum. You see. So these are erectus spinae, and this is quadratus lumborum, and this was. So they make a sheath. All they send a sheath, and from this sheath, lumbar sheath, all these 3 muscles, external oblique, internal oblique, and transverse, they rise and makes the anterior abdominal wall. If you see in the dorsi, then medially is your erectus spinae and quadratus lumborum internally. So these are the muscles cover posteriorly. This was more medially along with the are the picture of posterior abdominal wall. So I told you about the anterior abdominal wall. I told you about posterior abdominal wall. So that makes whole abdominal cavity, as you see. Okay. Now, and this picture, if you see this picture, is a very good picture. This shows. This is what latissimus dorsi. This is your what you call quadriceps lumborum, and these are anterior muscles wall, and this sits. This is this is above the arcuate line. You can see the rectus abdominis, anterior to sit, and posterior and linear. So this is what is all abdominal cavity. Okay, that's what you have to understand. This is what a typical what you call the uh, abdominal muscles wall anatomy. Now there are a lot of ligaments and tendons in abdominal wall. Uh, as I told you earlier, anteriorly we have got anterior rectus seat, posterior rectus seat. They are deriving from all the abdominal muscles. Posteriorly, they are quadriceps lumbar fascia and all the muscles. I'm not going into all detail about this and the couple of things. Now, when I'm talking of inguinal hernia, you will see that this is the inguinal ligament. Anterior superior spine to pubic tubercle. This is your anterior this is a inguinal ligament. Okay, uh, and this is what the transverse abdominis. This is your transverse abdominis, and this is internal oblique, and this one is this whole is or this one is external oblique. I say oblique. So this is the first layer, the second layer, and the first layer. The first outer layer, intermediate layer, and the innermost layer. And this one, you can see, is the posterior wall. This one is inguinal canal. Okay, opening from the internal ring. This is a cord. This is internal ring, and this is what you call covering from the external ring. Okay, I'll show you that. So this is what the keeping in this picture in your mind. Okay, and I'll tell you what exactly other structure comes in. So this is a typical picture of what you call. This is your inguinal ligament. This is your inguinal ligament coming all through down, and this is external ring, and internal ring must be somewhere here. And this is below the inguinal ligament. You can see the femoral artery, the femoral vein, and the femoral canal. Okay, and this is known as pectineal ligament, and this is the lacunar ligament or extension of pectineal ligament is a very sharp, tough from where the femoral hernia comes out. So this is what. So you can imagine how close is femoral hernia and this is external ring and this is femoral ring. So you can imagine how close they are. So it's very difficult sometimes to differentiate inguinal hernia with femoral hernia. Okay. Sometimes when femoral hernia comes out, it goes up and may lie somewhere here even anterior to the external oblique aponeurosis. So it is very difficult to diagnose the femoral hernia with the inguinal hernia. Okay. So that's a typical picture. Just keep it in the mind, and then you will understand the femoral as well as the inguinal hernia. Okay. Now, this is very important that many times when the examiner asks you about a division of the abdominal wall, you always get confused. Okay. Basically, abdomen can be divided by two ways. One is a quadrant. What you call the quadrant is 4. So this quadrant are divided into 4. How they divide it? One line from Giphisternum to symphysis line, and the transverse line between the highest point of iliac crest and the lowest point of the costal margin in between. Don't say umbilicus, because the umbilicus might change its position in the fatty people or in the thin people or might be very flabby people. The umbilicus might be not in the central position. Okay, umbilicus always lie basically in normal person. It should be at the level of 4 and 5 lumbar spine. Okay, lumbar spine. That's the level of the umbilicus. They might change it. They are very changeable. So when you talk about the landmark, you always take a fixed point. So bones are the fixed structure in the body. So you always talk about. So Giphisternum and symphysis line and transverse line that lies between highest point of iliac crest, the anterior cervical is behind it, highest point of iliac crest and inferior point of the costal margin. So in between, you can see this line goes. So they make a quadrant. So you use this quadrant when the pathology is lying in a bigger space of the abdominal cavity. If not, the best anatomical and well used division of abdominal wall is 9 zone or 9 regions. Okay? So that's you have to keep it in mind. So for that having 9 zone or quadrant, you have to have at least 4 lines. Okay, one line that runs from the mid clavicular line to the midpoint of inguinal ligament. Mind it, midpoint of inguinal ligament. Inguinal ligament is not a straight line. It is a bit slightly curved. So always say midpoint of inguinal line, inguinal ligament, not inguinal point. Inguinal point is something different. Okay, but always say because this ligament is a fixed structure. So always say midpoint of inguinal ligament and the midpoint of the clavicle joined together. That makes a vertical line, two vertical lines. Okay, and the transverse line is that 2 point joining the highest point of iliac crest. Okay, so this is the almost diagrammatically the highest point of iliac crest is joining them, and the lowest point of coastal margin, or the highest lowest point of coastal margin is just join them, and that makes a 9 zone or region. Okay, the right hypochondrium, left hypochondrium, epigastric region is center, right lumbar, left lumbar, and in the center, right iliac fossa, in abdominal cavity. Now, if pathology is confined to these of the zone, then you describe zone wise. The swelling is in the right hypochondrium or pain in the right hypochondrium. But if it is diffuse swelling covering more than 2 or 3 zones, then you go for quadrant. Okay. So always keep in mind the simple thing that the examiner will think of clearness. How do you understand exactly? Everybody says if there is a pain in the right hypochondrium, you will say upper quadrant. Don't say if it is confined to right upper quadrant means you say upper quadrant. It's a big area, and the zone or region is a small area. So always try to, because our work, all the effort is to cone down the diagnosis of any disease. That is more. So when it's disease means coning down, so space should be also coned down. If you say quadrant, is a very big space. If you say region, it is small space. Okay. In the region also you can say upper right hypochondrium or middle hypochondrium or lower hypochondrium or left or lateral hypochondrium. You can make it even for small region also. So that's how you use this abdominal wall division. So that's very important. Now, what is the function of abdominal wall? As you know, it supports all the viscera. If you don't have a flabby sort of abdominal wall, all your viscera will protrude out. That's why the abdominal viscera are they kept in shape or in position by the abdominal wall. And these all the muscles, some are transverse, some are vertical. When they contract, so they increase the pressure of the abdominal cavity, and it will try to expel things like in abdominal, in stool wise, urine wise. They expel out, or sometimes even vomiting. They expel out because of the contraction of the abdominal wall. So that's also a function of it. So it keeps the things in content. Okay, and as you know, there is always respiration that has got abdominal thoracic respirations. That's how the diaphragm will go up when you increase the pressure of the abdominal cavity, and when you decrease the pressure, it will come down. So lungs expand, air goes in, then they create exchange. So abdominal muscles also work as a respiratory functions, and movement wise, many times the abdominal muscles will help you to movement. If there are paralyzed patients, they develop so much that through the abdominal muscle they can move their lower limb. Okay, so that side also is helps in movement, and definitely it protects your internal organ. When you're something hitting you, you just contract your muscles and make it tight, so it protects the internal. That's the main function of the abdominal wall. So anything that inside the abdominal cavity will try to maintain the position of internal organs and protect them. And sometimes these abdominal cavity walls are useful in cases the transmitting or maintaining the heat of the abdominal cavity. Somehow, like एकछिनपछि फोन गर्नुहोस् सर, म एउटा क्लासमा छु. So that's the importance of abdominal wall. Okay, posteriorly or anteriorly, whatever it is. Now, having said that, I think I'll take you back to this diagram. Now, what is anterior abdomen? What is posterior abdomen? I couldn't make a diagram here. The anterior abdomen, usually if you see, basically is covered by a cavity within the parietal and visceral peritoneum. Okay, and behind the visceral peritoneum is retroperitoneum. Okay, so if you see the anterior abdominal wall, I think this might give you some idea. Yeah. So what happens? If you see, this is peritoneum. This is anterior peritoneum. Okay, anterior peritoneum goes there and turns and covers all the intestinal organs inside. Okay, and join here. So the space between this and the visceral peritoneum is your anterior abdominal wall, anterior abdominal cavity. So, and if you go behind, you see what happens. This is a peritoneum. It reflects and cover all the like here. It covers all the intestinal organs. So this is the anterior abdominal wall, and this is the anterior abdomen. And behind this, these spaces are retroperitoneum. This is anterior peritoneum or peritoneal cavity, and this behind this peritoneum is known as posterior abdomen. Now, how you differentiate from outside, which a landmark for anterior and posterior abdominal wall? So if you just see, then what you do, I have not that diagram, sorry. What you can have is that a line drawing from the mid-axillary line, okay, mid-axillary line, comes to the highest point of iliac crest. Then a line from the mid-axillary to highest point of iliac crest. So the part anterior to this line is anterior abdomen, and posterior to that is posterior abdomen. Though diagrammatically, I may not be able to correlate. So what happens? So this area, this from where it reflects back, is the point where the line from anterior mid-axillary to highest point iliac crest correlates. So that's a point from where the peritoneum reflects and cover to the intestinal organ. So when you tap the abdomen, you have to put your needle. You have to put your needle somewhere here and going down to here. If you put your needle below, then you will have a dry tap. You will not have any fluid. So you have to tap. So you have to tap the abdominal cavity above the line joining the mid axilla to the highest point of iliac crest. That's then anterior and posterior abdominal wall is landmark from outside. Okay, so these are the line marks I have told you. Now I'm coming to the topic is hernia. What is hernia? Okay, it's a protrusion of viscous organ or part of into a sac. If there is no sac, that's not a hernia, that's the emphalus. That is no hernia, that's not emphalus. But there should be a sac. The sac always is made of the parietal peritoneum. So when the parietal peritoneum protrudes out from the abdominal wall, and the viscous or part of organ or the content that will come into the sac. So that is not a hernia. So if you see this, because of weakness, or there is already a hole, anatomical structure, so sometimes they protrude out through that hole, like internal ring. Okay, if you see the internal ring, there's a hole which closes by itself during the birth. So if that hole is patent, then the parietal peritoneum will come out from that hole and come out from the external ring, and it will present as a hernia. In that sac, you can have any viscous or organ inside. So that's hernia. Like in umbilicus, if the umbilical fascia doesn't close by itself during the development of the baby or during the delivery, then there might be the peritoneum will come out from the defective umbilical sheath or umbilical opening, and there might be hernia. Okay, so these are the two already present holes in the abdominal wall, which might have a what you call hernia in later stage. Okay, and there might be abnormal protrusion of a viscous or part of the viscous through the opening, artificial or natural. I said natural means those in inguinal ring or in the umbilicus, they are natural or congenital. But sometimes, there might be hernia from other part of the abdominal wall. Like if somebody has a trauma in the abdominal wall, that area get weak and they develop what you call hernia from that place. Okay, or somebody has a surgery and the wound got infected and that part of the abdominal wall got weak, then there will hernia. Or somebody is very fat. Okay, so the muscles get split out, and through the splitted muscle, the peritoneal might be come out, and there might be hernia. So there are different ways of hernias. Okay, but as a single definition, this is a protrusion of any viscous or organ or part of it or any content in abdominal cavity through a opening into a sac which is already developed by protrusion of the parietal peritoneum. So these are the component of hernia. This is basic. This is general hernia means. Okay. Now it could be congenital, as I said, as the development of the failure, like internal ring is not closed or umbilicus is not closed, or in the abdominal wall. Sometimes what happens? There is defective abdominal wall, and only the peritoneum is there, parietal peritoneum is there, and there is defective. These are known as emphalus also. Okay. Sometimes there is no peritoneal wall, so it becomes major or minor. So that's a different topics to be covered. So why this hernia takes place? So there are two things now. One is abdominal cavity, and one is the abdominal wall, which is considered to be the two factors. If they are in normal, there will not be any hernia. But anything normal in these two, either in the abdominal cavity or in the wall, there will be hernia. So if there is intra-abdominal pressure increases, okay, especially in chronic cough, those smokers or old age or COPD patients, okay, so in their cough, so there is a sudden increase of intra-abdominal pressure. A constipation, when you go for toilet and you can pass the stool and you strain it, so what happens? All that pressure increases to push down the stool from the colon, so the intra-abdominal pressure increases. Okay, if you lift a heavy work, so the intra-abdominal pressure is lifted. Like heavy load bearer, those are our porters who would carry a very heavy loads, or people who are working in a very heavy industrial factories. Okay? And if you have got in old age, due to increased prostatic hypertrophy, what happens? They have to strain to pass the urine, or there is urine stricture in the urethra, so they have to force to pass the urine. So the intra-abdominal pressure. Crying, babies crying, or when you cry so like that, then also when there is ascites, that also increases pressure. Okay, or there is some growth or malignancy or pregnancy, that might cause things. When you stand for prolonged time, what happens? All the intestinal the contents, especially those are mobile one, intestine and colons, they go down and they increase the pressure in the pelvic abdomen, and there might be a protruding or pressure in the lower abdomen. So these all factors I can see which causes increase. Like teachers, they have to stand for a long time. So they stand having a pressure in the lower abdomen and increased pressure in the abdomen wall. So then that might be the cause of, if there is already pre-existing opening, so that pressure will more focus or cone down to that opening, and a hernia test like an internal ring, or might be in the umbilicus opening. Okay, that's one of the basic principle of hernia is increased abdominal pressure. And if the wall is weak, especially when the wall is weak, especially in normal person, when they get aging, old age, the collagen fibers, they don't deposit properly in the abdominal wall, in the muscle, in between muscles, so they can lax, so they become weak. So the wall is weak. Like in malignancy or systemic disease or illness, you have got low immunity, low resistance, then the muscles get weak and you develop hernia. Like injury, when they injury blow, okay, or surgery, what happens? That area becomes avascular, and that area becomes probably nerve sensitive is less, so they become weak and they protrude out. Okay, and repeated pregnancy, you have seen that, especially ladies who have repeated pregnancy, very fast pregnancies, their abdomen becomes so stretched and lax, so muscle get weak and they develop hernias. Okay, obesity is the same. And neurologic and muscle diseases, myopathies. Okay, and there are a lot of diseases, Pune belly syndrome or metastatic emphysema, read. These are all that has got a effect on the collagen depositions, or like in Down syndrome, these all babies, their collagen deposition is very low or not strong, so their wall get weak and they start having hernia. Okay, there are so many other causes that might come across. And lumbar triangle area, these are the areas where the muscle has very strong all around, but in the center there is not strong. Like in lumbar triangle, I'll come to that point. The inguinal areas or femoral areas, up to the foramen areas, sciatic foramen area, the muscles are there, and there is a small opening from where some of the structure comes out. So these are the places where they are weak in abdominal wall. So there are two factors you must keep in mind. One is increased abdominal pressure. That might be what I've said, listed you. There are many more other causes of increased abdominal pressure. There are many more causes of abdominal wall weakness. So you can list them. And these are the basic principle of the hernia development. Okay. So if you see the hernia, there might be internal, external, and intermediate hernia. So what is said that internal hernia is, they won't come outside. They will have hernia inside only. Might be inside the abdomen. They might herniate between the loops of the hernia intestine, between the mesentery of the intestine. So they might come out. And sometimes the most important is they might herniate from abdominal cavity to thoracic wall. Thorax, like backdoor leg, Morgagni hernia. The defect in the diaphragm, thoracic diaphragm in the center, or there might be defect in the center of the dome of the diaphragm, they herniate. There might be paraesophageal hernia. The hernia, especially the fundus of stomach, they squeeze into the thorax wall by the side of the esophagus. There are hernias like that. There might be hernia from the backdoor, the defect in the diaphragm, thoracic diaphragm laterally, or Morgagni in the center, in anteriorly. They might go. These are all internal hernias. Okay, they might like that. External hernia, but I'm dealing with you all the external hernias that will come later on. But sometimes what happens, the hernia herniates. The hernia comes out from the abdominal cavity, but they are not seen. They might be in the muscle layer. You can't see that. So these are the hernias where you can say intermediate type of hernias, where they are muscular hernia, intermuscular hernias. You won't see them. They have come out from the abdominal cavity, but they are not protruding outside, not seen outside, but they are lying in between the hernias. But The note is that herniation is a process of protruding tissue from inside out of the viscera walls. So anything like herniation means tentorial hernia. What happens? The midbrain, when there is increased intracranial tension, the midbrain, they protrude out into the spinal cord. So then it's a herniation. That's not a hernia. Okay? Because that's not a typical hernia because they don't have any what you call the sac. It's open like that. But even the internal hernia that goes from abdomen to thoracic, they have got the parietal peritoneum. They go in the thoracic cavity. That's a true hernia, but they're internal hernia. Otherwise, if you know there is no hernia without, if there is hernia without any sac, that's known as herniation. Is a process, not is a what you call true hernias. That you have to understand when you use this hernia word. So there are so many hernias. Okay. They could be just in between the umbilicus and gephysterum. They are known as epigastric hernia in the linea alba. So there might be some hernia from the umbilicus. There might be hernia just adjacent to the umbilicus, and is paraumbilical hernia. That might be superior to that or inferior to the umbilicus. There is Spegelian hernia. This is a typical intermediate type of hernia. It's very difficult to diagnose. Inguinal hernias, femoral hernias, obtruder hernia anteriorly, and there might be lumbar hernias that could be either superior or inferior lumbar hernias. There might be gluteal foramen or sciatic foramen, then a gluteal hernia, sciatic. These are the normally anatomical hernias, but hernia could be from any part of the abdominal cavity depending upon the cause. So these are the ones they have already have the openings which become so big and they develop hernia. These are the external hernias, but there might be any hernia like ventral hernia because the stretch of the lower abdomen you can hernia. There are hernia in any lumbar area, especially in the when you do a open kidney surgery, they get weak, or in the subcostal margin when you do what you call gallbladder operations, or in the umbilicus when you pass a port, the camera for the laparoscopy, there might be develop hernia. Okay, so these are the typically possible hernias having without any external cause. But there might be so many hernias, could be different hernias in the body. Okay, so these are the you remember by sequence: epigastric, paraumbilical, umbilical, Spegelian, inguinal, femoral, sciatic, and posteriorly superior lumbar, inferior lumbar, gluteal, and sciatic. Okay, these are the normally possible places where you get hernia, and this one of the type of hernia they classified when you talk of the hernia. And frequency of hernias, all the hernia not that common. The most common is male in both the male and female is inguinal hernia. There could be direct, indirect, unilateral, bilateral, or both of them direct, indirect in the same patient, in the same site. And most other common is what we call femoral hernia, which is most common in ladies, but it doesn't mean that it's not common in male, but they are common in male, but more common in female. But inguinal hernia is common in both the sex first, then only the femoral is common in female. Umbilical hernia, paraumbilical hernia, these are common hernias. Not very usual, but not uncommon also is epigastric hernia and diverging recti. The rectus muscles is almost just a centimeter away, the right and left rectus muscles, they are just 1 centimeter away. When it get more diverted or they get separated more than 1 centimeter, then there will be a gap in between which protrude out when intra-abdominal pressure increases. That's not a diverging recti. I'll come to the point. But the rare, but you must know is Spegelian hernia, obtrusive hernias, lumbar hernias, gluteal hernias, sciatic hernias. So these are the frequency-wise hernia in the body you can have. There is a lot of classification in general. In general, there are a lot of classification. I'm just describing you is the hernia when the content in the from the opening the content come out in the hernial sac. See, they have to go back. If they don't go back, there will be a problem. So if they go back, there is no reducible hernia. Either you manipulate it or it goes by itself. That's fine. There might be slight discomfort or pain, but it's good enough that they have gone back to their own original place. But if they don't go back, they are not reducible, then it's a problem. Then what happened? Either they will obstruct or they will strangulate because of the vessels, the lymphatic, the vein, the artery, they get occluded because of pressure, and then they will have a complication. And sometimes when the sternal hernia is not taken properly, they might get necrosis, and there will be perforation, and there will be incarcerated type. Sometimes there is inflammation of the hernia, there's inflamed hernia. So reducible hernia, fine, they goes back, okay. Irreducible, they don't go back, then they get obstructed, then the vessels are compromised, and there might be necrosis and incarcerated. Sometimes they get inflamed. So one classification in general is reducible and irreducible hernias. And classification otherwise that depending upon the content, what is the content inside their hernia is that's important. Okay. I'm talking about the abdominal hernia, which is seen, the external abdominal hernia. There might be this peritoneal fluid. Okay. In pediatric group, when there is a congenital hernias, patent petis process vaginalis, which is supposed to close during the birth, if they open it, that is a continuation of the parietal peritoneum through the internal ring to the external ring. Because from there, the spermatic cord, they travel through the internal ring to external ring. So during that time, they drag a layer of peritoneum, a tube of peritoneum, and going down. So they have to close. If they don't close it, so there is a patency between the abdominal cavity to the externally, that is known as congenital hernia. So in that one, usually you find the peritoneal fluid flowing. Otherwise, also in acquired in adult, also there might be fluid. Okay, so they might present in a different way. With the omentum is coming there, the first thing that comes in the hernial sac is omentum. There are no omentocele. If the intestine comes, then it's not enterocele. If only the circumference of intestine that comes, that's known as rectus hernia. If the Michel's diagonal comes, that's known as lictus hernia. If the double loop of the intestine, this is a medial hernia, I'll come to that point. And if the appendix comes, so amyline hernias, if the appendix comes there, the part of sac comes, sometimes the cecum might come, that is a sliding hernia. So depending upon the content, there might be large bowel, ovary, unibladder, there's so many things that might come. Even sigmoid colon come in the right side, you know. Sigmoid colon might come to the right hernia. So any content there might be there. And it's very difficult to say which part of the intestine has come. So depending on the content, it can be classified ometocele, enterocele, dicrocele, medial, sliding. So that's how you have to classify them. If you see the pathology, the more important, this is a very important diagram. More than the resistive power of the abdominal wall, if the pressure increases, okay, or it's a range of intra-abdominal pressure is there, then what they do is opening of the weak area of the abdominal wall, because the pressure that could be what we call maintained by the abdominal wall. So the weakest point, they'll find the weakest point, then that will open up. Okay. Then what happens? There might be, if there is abdominal wall is so strong and the intra-abdominal pressure is so high that they might stretch the muscle of the abdominal wall and they make it weak. Okay. Then from that weak point, protrusion of the parietal peritoneum takes place. So then there is a formation of sac. You see, so if the wall can't hold on, or the incremental pressure, so that pressure is focused in particular area where is weak in the abdominal wall, and they what gets protrusion of the parietal peritoneum, and they form a sac. And from that sac, you can have the opening in the parietal peritoneum and the swelling outside in the abdominal wall. You can see external hernia, there's no formation of sac. Okay, so that's what the basic pathophysiology of hernia or sac formation. Now you see, what is part of hernia? You can see that here is your rectus muscle, and this is posterior rectus sheath, this is peritoneum, prefrontal fat, posterior rectus sheath, anterior rectus sheath, and this is muscle, and they all skin, all this thing. So here was the weakness in between the muscle. So this peritoneum came out, protruded out, and from a sac. Okay, from the sac, and this is the content. Okay, so when you see the sac, there should be a mouth from where the content come down. So there is a neck, narrow part, and the body, wide part, and top is from this. So in a sac, it is divided into the mouth. You see, the is around there, the neck, the body, and from these are the part of the hernia. Okay, and if you see, this is sac. Okay, and this is the fundus, and this is covered by all the layers of the abdominal wall, which is which were lying in between before they have formed the sac. This weakness. So due to all the layers like skin, soft tissue, fascia, seeds, muscle, extracellular fat, or peritoneal sac, then there is a content of sac. So if you see from the outside, there will be skin, soft tissue, fascia, seeds, muscles, extracellular fat, then peritoneal, which is a sac, and the content. So these are the parts and content of a hernia. That's you have to remember. Okay, the more narrow is the neck, okay, the chances of getting hernia obstruction or irreversible hernia is very high, because once the intestine comes out, they're so tight here, it's very difficult to push. So always you try to push from one end, slowly, slowly. You can do what you call forceful pushing the intestine. You can do it like that. You can see now, this is the intestine, is a what you call distal intestine, this is a proximal intestine. This loop has come. Okay. So there is a compression. So what happened? The proximal loop is getting bigger and distal loop is smaller. So because of obstruction here, that means the proximal loop becomes bigger and there is a feature of obstruction. Okay. That's what is the important part we should understand. I'll come to the point later on. Then clinically, what happens in general, that is, you can use these points for any hernias you can come. Okay, there will be mild pain because there is stretching of the muscle. There will be stretching muscles, so there is mild pain or moderate pain or severe pain sometimes, and you can see any swelling, a prominent, which comes and goes back. That is a reducible type. So depending on the increased intra-abdominal pressure, if you cough, you can see a bulge coming out. And after when you relax, it goes back. When you stand up, the bulge comes out, or when you lie down, it goes back. So that is some swelling which comes and goes back. When the swelling comes, you might feel discomfort or dragging pain. It might be moderate or morbid depending on the size of the hernia. And when this hernia goes back, okay, there might be nothing. It will be very easy, it goes back. But sometimes it makes a gurgling sound when it goes back, or you manipulate it and push it inside. There is a gurgling sound. That means the intestine has come in the sac. That's how you see during the reducibility. Or dragging pain is because, you see, when the intestine comes, or when the momentum comes, it drags the mesentery. So the dragging pain will be more towards posteriorly in the lumbar region, probably from the second lumbar region to the iliac crest, right side. There is a fibrous tissue where all this mesentery there hang. When the intestine comes in the hernia sac, and hang down, it pulls that mesentery and puts that uh, fibrous tissue structure where that mesentery is hanging. So there is a pull of that, the root of the mesentery, where you get pain backside. So in hernia, if somebody says, I've got pain in the backside, that means always think this is quite a big hernia, and pulling down the omentum or intestine is coming out in bigger length. That's very, very important in clinical feature of a hernia. Okay. And what you see a swelling, which is reduced by itself, or you have to manipulate to reduce it, or you may not reduce it. It's just lying outside. Okay. Or it might be soft, might be well defined, or may not be well defined. The shape depends upon the shape of the opening and the content. Like you can see that some changes in the color of the skin over that swelling, because the stretching of that skin, they might change the color. And when you ask the patient to cough, you can feel the cough impulse over the swelling when you put your hand, and you can see that. And if you just reduce that swelling and see, you can see a defect in one in the swelling in the abdominal wall. There might be a defect, and you put your one of the finger or thumb and ask the patient to cough. Then you will not see any swelling coming out, but you can feel a pressure in the finger when you occlude the opening of the hernia. That's known as occlusion test. Then you try to find the etiological, what is the factor that causing the intra-abdominal pressure increase? Whether it's a prostate, whether it's a chronic cough, whether it's a ascites, whether it's a pregnancy, whether it's a malignancy, or anything else in that, or whether it's a weakness of the wall, any immunocompromised diseases, or there is a collagen fibers not properly formed, or the congenital problems, then you can see that. Okay. And the most, in case of inguinal hernia, you have to see the scrotum to see the content. Okay, that's very, I'll come to the point. And you see the general condition of the patients, whether it's anemic, malnourished, or not properly exercise, or having what we call different work or profession, which might cause increase the intra-abdominal pressure. So these are the things you have to find in the sign. Okay, when you to diagnose the case. So usually the swelling, you see external swelling in any hernia, you have to differentiate with the lipomas, or you see mangiomas, or lymph nodes, or varicose vein, or fibroma, or might cyst like dermoid or sebaceous cyst, or depending on the specific area of the hernia, there might be see any local cause which is more common in that area, like in femoral saphenopharynx, like in inguinal region, might be undescended testis, or retractile testis, or ectopic kidneys. Okay, in epigastrium might be peptic ulcer, depression like that. Okay, or in the umbilical hernia, they might say urachus cyst, or might be what you call congenital mesenteric cyst. So you have to differentiate depending on the area of the hernia where it is situated. And investigation-wise, the most important is, the best is ultrasound. That give you a good idea. It might give the site of the opening defect, and the size of the defect, and the level of defect, and the content of the sac. MRI is good for soft tissue, this thing. And laparoscopically, you can push your laparoscope and see from where is a defect in the abdominal wall. But you see, herniography is a old standard sort of investigation. Previously, we didn't have ultrasound or the MRI. What they used to do, they push the dye, dye in the abdominal cavity, and ask the patient to lie down towards the site of hernia. So all that dye is go and collect in the hernial sac, and they take an X-ray and see the hernia site, which is known as herniography. Not done nowadays, just historical now. Then you have to go for baseline investigation, like if there is some immunological thing, or diabetes, or hypertensive, so you investigate that. And if you want to go operate, then you have to investigate for pre-operative preparations. Anesthesia you can do depending on the site, you see, or general anesthesia, or spinal, or local. Like many times in inguinal hernia we do for local, femoral hernia we like the spinal. So that depends on. I'm like always in general, not spine. So there are a lot of hernias, like epigastric we can do in local hernias, small hernias. Big hernias you have to go for anesthesia. Or sometimes you can do a conservative treatment. You can wait. Sometimes, in early age, small hernia, they might spontaneously close itself and cure. If not, then you have to do a different procedures. Like herniotomy means you just excise the sac, okay, and don't do anything. Or herniography, you excise the sac and push that content and everything, and push that the sac, or cut the sac in the mouth and suture it, and that defect is ROFO, like a ROFO herniography. Or you can put the mesh or any external strong patches to protect that area. Or nowadays you can go for laparoscopic hernia, minimally invasive surgery, at different techniques. I'll come to later on that point. And that's how you, in general, we see the hernia in this. Now, next lecture in Thursday, I'll take a bit more time and try to cover up all the different type of hernias, still focusing on inguinal hernias or femoral hernias and the epigastric hernias or molecular hernia. So that's for today.